So again, tonight's review is just on the updates to heart failure. And as per usual, we're gonna just go over, when we report any treatment, any procedure, we usually give it a class of recommendation. So you guys need to know class 1 indication and class 3. Especially people doing exams, you need to know class 1 and class 3 indication. So again, when we say something as a class 1 indication, it may be a procedure or it may be a treatment, medication. It is recommended. And if you practice in the United States, then it's tantamount to malpractice if you don't prescribe the treatment or do the procedure. So it is recommended, it's indicated, it's useful, it's effective and beneficial, and it should be performed. So, that is a class 1 as opposed to your class 2. Class 2 is divided into class 2A and class 2B. 2A, is reasonable, and it is effective, it is beneficial, and the treatment should be carried out. Whereas class 2B, it's a little weaker indication. It is suggested, but there's not a wealth of data to support a class 2B indication. And then when we talk about class 3, you have a class 3 medication or procedure may not have any benefit, it may not help the patient. But the class 3 that we're really concerned about is those treatment or procedure that can harm the patient. So you have to know if there's any strategy that you can perform that will hurt the patient. So class 3 is definitely contraindicated. And then we have our level of evidence. It's just basically the data to support what you're doing. Level A, you have tons of randomized controlled trial. B, you have a few, not as much, and then BNR. So the important thing there is to know the class. Okay. Okay. So we're gonna delve into the updates. So the purpose of this focus update is to update the 2013 American College of Cardiology Foundation / American Heart Association guidelines for the management of heart failure in areas in which new evidence has emerged since its publication. So if some studies are finalized and the results are known, then it's included in the updates. For this update and future heart failure guidelines, the Heart Failure Society of America has partnered with the American College of Cardiology and the American Heart Association to provide coordinated guidance on the management of heart failure. So this is just a focus update. And as I said before, it's not a lot of updates. There's updates on the biomarkers, and as you remember, we do a lot of BNP. The two assays that we are doing is the BNP, that's the B-type natriuretic peptide, and the NT-proBNP, that's the N-terminal pro B-type natriuretic peptide. And if you remember how we get to these, so with increased stretch, especially in the atrium, the atria and the ventricle, you produce what we call proBNP. So you're going to get proBNP produced by stretch. So whenever you have heart failure, you're going to produce pro-BNP. And this is a sort of compensatory mechanism where when you produce the pro-BNP, that pro-BNP is cleaved to give you the NT pro-BNP. That is your NT pro-BNP. And then you also get your BNP from that. So again, it's a compensatory mechanism. Whenever you have heart failure, when you get heart failure, you get increased left ventricle filling pressures, and that causes stretch in the chambers, the atria, and that you're going to produce the pro-BNP. Pro-BNP is going to cleave to give you an NT-pro-BNP and a BNP. The BNP is the biologically active peptide, and what it does, it causes fluid, sodium and water diuresis, and it causes vascular dilatation. So the BNP is metabolically active, and it does a lot of beneficial things. But the thing about BNP, it is broken down by an enzyme called neprilysin. So the BNP is broken down by neprilysin and rendered inactive. Okay? Okay, so this is NEP. So just use your imagination. This is an E. So the BNP is broken down by neprilysin to give you an inactive metabolite. Now, so an inactive metabolite. Now we have medications that can inhibit this enzyme. This neprilysin enzyme can be inhibited by neprilysin inhibitors. So therefore, you prevent the breakdown of the BNP. So you'll have more circulating BNP, which, again, as we said before, is metabolically active, causing vasodilatation and salt and water diuresis. So it's going to be beneficial for the patient to get rid of fluids and salt. So what they have done is combine this neprilysin inhibiting enzyme with angiotensin receptor blocker, and the combination is called ARNI. So the ARNI stands for angiotensin receptor neprilysin inhibitor, and it's commonly known as Entresto, which is a combination of the neprilysin inhibitor and the angiotensin receptor blocker, valsartan. So this is now one of our mainstay in the treatment of heart failure, and we're gonna just look at how the okay. So there are other things that can cause an elevated BNP, but before we get there, so when we do when we make the assessment of heart failure, someone comes into the hospital, shortness of breath, orthopnea, PND, leg edema, we suspect heart failure, we get a BNP level, okay? And if it's heart failure, it's usually elevated. If the patient is on a neprilysin inhibiting drug, if the patient is on neprilysin inhibiting drug, then it's going to block the breakdown of BNP. So you're going to get an elevated BNP anyway. So if your patient is on ARNI, which is the angiotensin receptor blocker and a neprilysin inhibitor, you shouldn't get a BNP. You need to get an NT-proBNP. So the level, and people doing exams, this is another question. So you would not, patient comes in with shortness of breath and you suspect heart failure, they're taking Harney and Entresto, you don't get a BNP level. You get an NT-proBNP level because the neprilysin inhibition is going to increase your BNP, so you don't want to do that. So there are other things that can elevate your natriuretic peptide level. We mentioned heart failure, RV, including RV syndromes, acute coronary syndrome, heart muscle disease, LVH, valvular heart disease, pericardial disease, atrial fibrillation, myocarditis, cardiac surgery, cardioversion, toxic metabolic myocardial insults, cancer, medicine that cause myocardial insult, and there are non-cardiac causes, just as advanced age, anemia, renal failure, pulmonary disease, obstructive sleep apnea, severe pneumonia, pulmonary hypertension, critical illness, bacterial sepsis, and severe burns. So we dealt with this when we did the guidelines. So we just basically just went over it again. Now, so this is, so when you see modified, that means the guidelines are modified since 2013. And so when the patient comes in, a class 1 recommendation is the measurement of BNP or NT-proBNP to establish prognosis, okay? Or to look for disease severity in chronic heart failure. So that is a 2013, that still stands, but it is modified in 2017, measurement of baseline level of BNP or other cardiac biomarkers such as troponin on admission is useful to establish a prognosis in acutely decompensated. So we're not talking about chronic heart failure now. A patient comes in with acute heart failure. You should do a BNP level. Current recommendation emphasizes that the admission level of the BNP that is useful in terms of doing prognostication. So you get a BNP level in the acute heart failure when the patient comes in. Again, during a heart failure hospitalization, so the patient is admitted with heart failure. They're before they're discharged, a pre-discharge BNP level can be useful to establish a post-discharge prognosis. So when they're admitted, you'd get one to see how sick the patient and to establish the diagnosis of heart failure. Before the patient goes home, you'll also get a BNP level because current recommendation reflects new observational studies that suggest that your pre-discharge BNP also can give you some type of prognostic data on these patients. And also in patients with chronic heart failure, the measurement of other clinically available tests, such as biomarkers of myocardial injury or fibrosis. So we spoke about the troponin I and troponin T and the galactin 3 and the ST2. So those are, you can look at those other biomarkers to consider for additive risk stratification. So that, but we went over this in the 2013 guidelines, but this is now a class 2B. indication, whereas the pre-discharge BNP is a 2A. Remember, when a patient comes in, is admitted, and you get a BNP, that's a class 1 indication. Okay, so it's not a lot of changes. So patient comes in either chronic or acute CHF, you're going to get your BNP or NT-proBNP. Remember, if the patient is on ARNI, Entresto, the BNP is not going to be accurate. It's going to be elevated. So you need to get an NT-proBNP. People doing exams, NT-proBNP level. Okay, and then you can, pre-discharge, you can get another BNP or NT-proBNP. Okay, so these are all class. So this is a class 1. The pre-discharge is a class 2A. Okay. Other biomarkers that you can get is the troponin level as well. And as we mentioned, the biomarkers for fibrosis is the galactin-3 or the ST2. So the ST2 receptor and the galactin-3. Those are other biomarkers for fibrosis. All right, so other updates. So you see, it's not a lot of updates. Now, for you to remember, we said that when your patient is in heart failure, as a compensatory mechanism, they're going to increase aldosterone production, and we use aldosterone antagonists in these patients. You're only going to use your aldosterone antagonist, this is your aldactone, spironolactone, eplerenone, if they have class 2 to 4 heart failure. So again, this is important for patients, for people doing exams, class 2 to 4 heart failure. Remember, you want to give your aldosterone antagonist if the creatinine clearance is greater than 30, or if the potassium is less than 5. It's important. So if you're going to use ARNI, if you're going to use angiotensin receptor neprilysin inhibitor, then you have to discontinue your ACE or your HARB about 48 hours. So roughly about 48 hours before you start the ARNI. Okay. What about hydralazine and nitrates? Remember that combination? Again, New York Heart Association, class 3 to 4 in Black patients. And people doing the exam, I'll bet each of you $100 that this question comes. Because I mean, that's how they set their exams. In Black patients, New York Heart Association, class 3 to 4, they're on guideline directed medical therapy. They're still symptomatic. You add hydralazine nitrate combination. It's a class 1 indication. Okay. All right. Again, what about the ICD? Implantable cardioverter defibrillator. Again, class 2 to 3 heart failure, ejection fraction less than or equal to 35%. They have to be living. They have to have a lifespan more than a year, though. Okay. If it's post a heart attack, it should be 40 days after the heart attack. 40 days after the heart attack, then they get an ICD. You don't want to put it in too soon. You have to give the heart time to remodel. That ejection fraction may remodel and get back to 50%, so they don't need the ICD. Okay? Remember 35%, that's equal to 35%. They have to live for more than a year. What about CRT, which is your BiV pacemaker? Again, ejection fraction less than or equal to 35%. Okay. It should be in sinus rhythm. QRS should be greater than or equal to 150 milliseconds, and it should have some evidence of left bundle branch block, or the ECG should have a left bundle branch block pattern, and that's a CRT. So these are class 1 indication now. Again, when you're tested, they're going to test you in class 1 and class 3. In the beauty about when you're practicing medicine, you can Google stuff. You can Google stuff and look at it. When you're doing the exam, you can't really Google anything. So you have to know. All right. So remember 35% or less, wide QRS, left bundle branch block pattern by the pacemaker, CRT, cardiac resynchronization therapy, and then for the ICD. What about ivabradine? I've never, I shouldn't say that. I've never used this medicine, okay? This medicine have a class 2 indication, and I really don't think it has any place in heart failure treatment. All right, so you're gonna give it, the patient have to have heart failure with reduced ejection fraction, class 2 to 3. The patient have to be in sinus rhythm. This medicine only acts on the sinus node, and the heart rate has to be greater than or equal to 70, but they have to be on maximal, they have to be a maximally tolerated dose of beta blocker. And I've never seen a patient in sinus rhythm on maximally tolerated beta blocker with heart rate greater than or equal to 70. It has a class 2A indication, ivabradine. I don't really think it has a place in heart failure. It's a very strong statement, but I really don't think it does. All right, so these are the current recommendation. They're green class 1 indication. So if you have your stage D heart failure patients and they're on guideline directed medical therapy, and you put your devices in, your ICD, CRT, and these patients are still very symptomatic, then you can send them on to transplant, or you can do palliative care. They don't want it, or you can do VADS. We'll talk about LVADs, and LVAD can be a bridge to transplant, or it can be destinational therapy, or you can get them enrolled in some investigational therapy. All right. Um, so there's not much updates, to be honest with you. We talk about the ARNI, okay? The patient is on the ACE inhibitor or a ARB. Before you start the ARNI, you have to stop the ACE or the ARB, give them 48 hours, and then you start your ARNI. I usually start at 26, 24, and I will bring them back in, say, a couple of weeks or a month, and I'll go up to 49, 51. And, the maximum dose is 103.97. So, and it's twice a day, so you can see if they tolerate that. So, you should always try to get the patient on goal therapy. Again, ivabradine, it has a class 2A indication. So ivabradine can be beneficial to reduce heart failure hospitalization for patients with symptomatic, that is New York Heart Association class 2 or 3, stable chronic heart failure, ejection fraction is less than or equal to 35%, who are receiving guidelines directed medical therapy, including a beta blocker at maximum tolerated dose, or in sinus rhythm. Patient have to be in sinus rhythm, a heart rate of 70 beat or greater. Okay. So people doing an exam, you don't even have to know this, because they're not going to give you 2A indication. People treating patients with heart failure, you're probably never going to use it, and it's expensive. So another update. this is okay. This is, yeah. So your aldosterone antagonist. You want to make sure that your GFR is greater than 30, creatinine is less than 2.5, potassium less than 5. Okay, so you know that's important, and you have to know the schedule. You have to get a BNP 3 days, 1 week, 1 month. All right. Another important thing, you don't want to use nitrates and your phosphodiesterase 5 inhibitors to increase activity or quality of that. You don't want to give that, okay? Uh, so you don't want to give that combination of nitrates and your phosphodiesterase 5 inhibitors, all right? So, you know, phosphodiesterase 5 inhibitors is stuff like Cialis, Viagra. You don't want to give that. You will kill the patient. You mentioned most of those. Okay. So the thing about iron, okay, so in patients with New York Heart Association class 2 or 3 heart failure, and if they have iron deficiency, ferritin level less than 100 or 100 to 300, if the transferrin saturation is less than 20%, you can give them intravenous iron replacement. You can give that. That's so you can give them IV iron replacement. However, this is a class 3, so you have to know class 3. In patients with heart failure and anemia, you don't want to give them erythropoietin stimulating agents. It's a class 3, so you need to know it. So no erythropoietin stimulating agents if they're anemic, all right? So that can harm, no benefit. Now for blood pressure, so we did hypertension guidelines. Remember the two numbers you need to know, 130/80, 140/90. For heart failure, you have to be aggressive, so you need to treat the blood pressure to less than 130/80. Okay, so again, for you need to treat the blood pressure less than 130/80. So people doing the exam need to know that. So that's the thing. This is heart failure with preserved ejection fraction. And again, 130/80, the same thing. So, you know, patient of renal compromise, the patient is diabetic, treat that blood pressure to less than 130/80. What about your patients with sleep disorders? So this is important because it's also new. It's in the guidelines. In patients with New York Heart Association class 2 to 4 heart failure and suspicion of sleep disorder, breathing, or excessive daytime sleepiness, you need to do a formal sleep assessment, sleep study. If you suspect sleep apnea, do a sleep study. Okay? So it is, you know, you want to see if the patient have, you know, obstructive sleep apnea versus central sleep apnea. And if the patient have sleep apnea, it gets a 2A indication, so still do it. 2B, if the patient have you know, heart failure and sleep apnea, then CPAP, continuous positive airway pressure, may be reasonable to improve quality and daytime sleepiness. So that's also new. You do a CPAP, sorry, you do a sleep study. If they need CPAP, then you put them on the CPAP. This is probably just for people doing exams. So if the patient have central sleep apnea, there is something on the CPAP that we call adaptive servo ventilation. Don't use use that. It can harm the patient. So it's, don't use your servo ventilation, adaptive servo ventilation. That can harm the patient. That's new. So new data demonstrates a signal of harm when adaptive servo ventilation is used for central sleep apnea. So don't use that. So those are the updates, and again, it's not a lot. I think we did cover heart failure in depth. I would strongly recommend that you go over the lectures to refresh yourself, and it was very exhaustive, and I think it covers all the important areas. So we're gonna stop here.